We're going to go to our last speaker, which I think is a very important talk, specifically for those who are practicing bariatric surgery in the United States of America, as we're trying to release to public comment the new guidelines. Dr. David Provost is the one behind the scenes championing ACS-ASMBS efforts in setting up the new accreditation guidelines, and it's a great opportunity to hear from the lion's mouth, what's going on. We have to be here out by noontime. David, thank you very much for coming and taking this challenging talk.
We are running a little late, so I don't think we'll have time for questions, but if you do have any, I will stay around. What we need to talk about is why do we have the new program? What drove us to the concept of needing a unified program, what the differences are going to be between the current programs we now have and what the new program will look like, and then basically touch a little bit on the controversies, disclosures. So the MBSC QIP will hopefully by this fall be implementing our new criteria, giving programs the opportunity to participate in an accredited quality improvement program that really goes beyond the COE programs we now have. What we have been doing is accrediting programs, but really having very little control over what programs do with respect to their outcomes. We look at processes, we look at buildings and pathways, but we really have not been able to do anything with the actual outcomes. And there are questions as to whether we've actually had an impact on those outcomes. There clearly have been marked improvements in the outcomes of bariatric surgery since the initiation of the COE program. The question is a cause or effect. Certainly the reason we initially developed these programs in the early 2000s was because there were high complication rates in bariatric surgery. There was certainly negative press. Many of the private insurers were starting to pull out their bariatric coverage, and we really needed to grab hold of the problem and take it under our control as opposed to having somebody dictate to us what we should do. We have seen a significant reduction in mortality. We all now report our outcomes to a database, although the BOLD database has been very difficult to get your results back out of it. We report it, but we don't get much in return. What determined who was a COE or not? Really, the main factor was volume, and that number was 125. It led to some lower volume programs dropping out of the market, and at least with the original SRC COE program, we had 10 standards. These standards have been modified over time, but it really is very little to do with outcomes. CMS does support the COE process, and it is a requirement. But the membership felt like we needed to have a better program. One, the volume issue really bothered a lot of people. It was very difficult to get to 125 cases if you didn't have COE because you couldn't do Medicare. Many of the private insurers required higher volumes as well. Many people had done lower volume programs for extended periods of time, doing very good work, very low complication rates, and they weren't getting to be accredited. We've always wanted to go from a volume-based program to a quality or outcomes-based determination, but we just weren't making any progress towards that, certainly not with the former relationship with the SRC. There wasn't a quality improvement process within the program, and so we thought that it was very important to try to advance and improve this program. There was also a poll of ASMBS members where the members overwhelmingly voted that they would like to see a single program. We had the college program, we had the SRC/ASMBS program. It was confusing to payers, it was confusing to patients, it was difficult for us as surgeons, and so we felt like, one, we wanted to have a combined program, and two, we wanted to make it more of a quality improvement program as opposed to just a COE process. And the key is process improvement, and to let us be able to look at our outcomes, see where we vary from the norms, and then be able to act upon that to try to improve my results, allow sharing of information between surgeons and various programs to be able to improve the results of the group as a whole, and in doing so, overall improve patient care. So how do we assess excellence? And really we've used volume for now. It's a structural measure. It's really a proxy for true performance, and it's not always associated with good outcomes. There are process measures and pathways, support groups. We don't know which of these process measures actually improves outcome. There's very little data. A lot of this is based upon opinion, expert opinion, but really little data to support a lot of the things that we have required up till now within our COE programs. And then there's outcomes. The problem is that, one, the incidence of mortality is so low, the overall complication rate has improved so much that it makes it very difficult to use pure outcomes as a discriminator between who's doing well and who's not. And when we actually look at risk-adjusted outcomes, it's still difficult. And that's because the baseline noise, the just random events, the random mortality, the random complication that happens without predictable risk factors are actually greater than those that you would predict based upon patient risk factors and other risk factors. And so people have come up with what we call a composite measure, and that actually pulls a little bit from all of this. We looked at risk-adjusted outcomes. We look at volume, which is an important determinant. It's not the sole determinant. We look at, you can actually look at how you do with other operations. You can look at processes, but you combine all of these and you're able to come out with a better predictor of outcomes. And this was done initially in the Michigan Bariatric Surgery Cooperative. And basically what we're looking at are the ability to predict and stratify hospitals. First column is just based on volume, which gave you very little prediction. If you actually looked at complication rates in the middle column, you started to see separation. But when they used a composite measure, it actually was able to explain 89, nearly 90% of the variation between hospitals. So it's a much better tool than just looking at straight complication rates. And so the goal, one, if we're able to look at our outcomes, we're able to compare them in a risk-adjusted fashion, we can then begin quality improvement. And quality improvement is going to happen at 3 levels. And really probably the most important is the local level. That is at your practice, your facility, your program in your hospital. You look, okay, you get your outcomes, you say, okay, my readmission rate, my ER visit rate is higher than the norm. Then you develop a quality improvement program to focus on that, try to determine what the cause is, you implement a solution, you then track that and see if you actually improve your overall outcomes. And that's the kind of processes that we're going to try or attempt to get everyone to participate in and to improve overall quality of care. The next level is the more regional level, and this is going to be based primarily out of the state chapters where your state, because there are issues that are regionally important, particularly from insurance standpoints or requirements or things that we can look at, get groups together, look at quality improvement programs, and then the final are national quality improvement programs that will be based through the society. And there you can take on big issues that likely apply to everybody, such as venous thromboembolism prophylaxis, things like that. An issue of a regional collaborative is the Michigan Collaborative. They looked at VTE prophylaxis, and this is just kind of the numbers of patients in their database who got various combinations, low molecular weight heparin, unfractionated heparin, nothing in the pre-postoperative and post-discharge phase. And when they actually looked at the outcomes, they found that low molecular weight heparin had the lowest incidence of VTE. Interestingly, those who gave no preoperative prophylaxis had the highest bleeding rate. Why is that? It's probably because you see a lot of bleeding. It's a technical problem, but you blame it on the heparin, so you stop giving heparin, but your bleeding persists because it's not the heparin in the first place. But that was the finding they had. If they looked at postoperative prophylaxis, again, the lowest incidence with the low molecular weight heparin. And so they developed a plan that they wanted to implement statewide, where they a scoring factor based on various risk factors, and then a practice guideline. Everybody was recommended to get the low molecular weight heparin preoperatively. Everybody got it postoperatively, and those in very high risk actually got therapeutic doses, and then the medium and high risk got it post-discharge. And with that, they saw a significant decrease in their incidence of venous thromboembolism, and an actual side project of this quality improvement process. They demonstrated that even with risk adjustment, the use of preoperative prophylactic IVC filters increased mortality, and they were able to actually significantly decrease the use of prophylactic filters, and with that see improvements in the mortality. If we look at the red line, it's the overall decrease in mortality in bariatric surgery over time, but they've actually been able to show a greater decrease through their quality improvement processes. So what have we done? This whole thing started back in February 2011, about 2 years ago. Quality and Standards Committee was created to, one, take care of the BOLD database, look at the data, and also start reviewing all the criteria, determine which were valid, which weren't, what we needed to do. And then the EC approved to develop the quality improvement program. We met with the college, and an agreement was made to work towards joining the two programs. The databases were reviewed to determine which would be used. The joint bariatric surgery credentialing guidelines were developed, and these have actually recently been approved by the governing bodies. In December of 2011, we had the real thing that accelerated this process, and that was the problems with the SRC, which led to the termination of that contract, and as a result, the formal merger of the programs last spring. All programs within both groups, the college and the ACS-ASMBS programs, have remained certified and accredited. We now are participating using the BSCN database. They created the Committee of Metabolic and Bariatric Surgery at the college. Their standards subcommittees, a verification subcommittee, an outcome subcommittee, and then the new criteria were revised. These were put out for public comment December and January. There were over 600 responses from the membership, and really these were looked at very seriously, and actually came to a rewriting of the criteria. We took these seriously. We have redone it, and the new criteria will be coming out hopefully within the next month for an additional series of public comment. But what's different between the old COE process and the new QIP? Well, we've taken out a lot of things that we think are unproven or unnecessary. Nobody has shown that we need interventional radiology. We need to be able to place a percutaneous drain, but whether you need ER, IR in your hospital, you probably don't. And if you don't have it because you're a small facility, but you have a transfer agreement in place with the hospital that does, we'll start accepting that. And you don't need a cardiothoracic surgeon. You don't need infectious disease doctors. So a lot of those things were eliminated. We made surgeons' call coverage much simpler without the requirement of having to scrub on X number of bariatric cases. So really, a general surgeon who's credentialed in foregut surgery and takes ER call ought to be able to cover bariatric surgery. We are going to require some CME in bariatrics, but they don't have to have scrubbed on a bunch of cases. And then the main key is going to be the addition of the new quality improvement program. With the responses to the public comment, one of the things that has changed is that of surgeon certification. This was initially a component of the ACS-ASMBS program, but not the college program. One, credentialing is really a local process traditionally. The problems with certifications that any credentialed surgeon, not certified by a national program, but credentialed locally by the facility, could do bariatric surgery at a COE facility. We did not capture that data. We only captured the data from the certified surgeons, and really there was little impact on the COE process. But a lot of surgeons felt very strongly that their accreditation gave them bargaining power with their hospitals and facility in order to be able to get things that they felt were important for the bariatric program. And because of the very strong comment, there is going to be a certification process for surgeons. This has been approved. The colleges recognize that this is an issue. While it's relatively new for them, they have done it within the breast program. And there is going to be a certification that will be linked to the quality improvement process. What about bands? There are volume requirements with the new program for stapled procedures. There initially weren't for bands. Why was this? Well, nobody's been able to demonstrate that there is a volume outcomes relationship with band surgery. Actually, the BOLD database suggests that there's not one. But most people felt like you, one, need some form of a minimum volume just to be competent and to take care of the patients. It probably has a little to do with perioperative complications, but certainly outcomes probably are tied to volume. And so there will be a 25 case annual volume for the band-only programs. Programs that elect to be band-only will not be certified to do stapling programs. Doesn't mean they can't. They're not going to be, CMS won't recognize them as such. They can work on building their volumes to be a comprehensive program, but they will be certified for band only. What about volume? The 125 number was not supported in the literature. Looking at it, there appears to be pretty good evidence that 50 stapled procedures for a facility does appear to be supported. You also need enough cases just to support the infrastructure that's required to have a complete program, and so the stapled volume is going to be 50 cases. And over time, with more database and risk adjustment, we may be able to eliminate that completely, but right now we are going to need a case volume. Another thing, a lot of criticism was that surgeon attendance at QI meetings. We were requiring 3 per year for each surgeon out of the 4 quarterly meetings. Have surgeons operate at 5 hospitals, that's 20 meetings. They say they're not going to be able to do it. You also have a hospital that has 20 surgeons. Being able to get 20 surgeons at 4 meetings at least 3 times a year was going to be difficult, and so these will be loosened. The adolescent issues remains a problem, and that's because no adolescent program is going to ever meet volume requirements. And so there needs to be something to allow the pediatric hospitals to participate in the quality improvement process. There will not be restrictions on adult programs who want to do kids. There are a few things you're going to need to do. You're going to need to have a pediatrician who participates in the evaluation of the patients, or at least on the bariatric committee, but really that's about it. And a pediatric psychological evaluation is felt to be important, but other than that, adult programs can operate on the kids. So we hope to have the revised criteria to be put out in May, begin accepting new applications in the fall, and certainly current programs will remain within the program. We may start doing some renewals this summer just to keep on track with the CMS requirements. We will continue to use the old criteria until the new program has been fully adopted. There is one kind of new bump in the road, and that's there is a new NCA looking at the requirement for COE certification in order to do Medicare cases. The college, the ACS-ASMBS, have all sent in briefs strongly supporting continuing the facility certification requirement, but we've also taken this as an opportunity to lower the volume requirement, and Medicare is going to look at the lowering of the volume requirement from 125 to 50 stapled cases. And when you think about, okay, are we really getting something from the COE or the QIP program process? And if you think that you don't have much pull with your hospital now, if we didn't have the certification programs, you really would have very little pull in trying to get the things we need, the dietitians, the resources, to be able to support your bariatric program. I think there is tremendous benefit with this entire process. Thank you.
Thank you, Dave.